All right. So this is my second attempt at recording your chapter 4, diffusion of pulmonary gas review. Sorry, my first one was a little choppy and the dog was barking a lot, so I didn't want you to have to listen to that distracting lecture. So here is round 2, or my second attempt at this. So, as I mentioned before, this lecture really is a review for all of you. It's meant to just give you a little bit of a refresher on the diffusion topics and the ideal gas laws that we talked about in respiratory survey, because next week before spring break, we're going to be talking about fluid balance and electrolytes. And then after spring break, we're getting into some subject matter that those two modules will give you some good background information for. So that's why I included these before spring break, just to get you in the right mindset, make sure your background's solid before we get into gas transportation and acid-base balance or acid-base regulation. So I'm just going to get my big old head out of the way here and then move on. So talked a lot this semester about the definition of ventilation. So ventilation is talking about movement of air into and out of the lungs. That's ventilation. But once it gets into the lungs, it then has to get into our blood. So the process of the movement of the gas from our alveoli into our bloodstream is called respiration. Okay, and that movement of gases across that alveolar capillary membrane, that process is called gas diffusion. So to really appreciate gas diffusion, you need to understand some of those important ideal gas laws that we talked about in respiratory survey, specifically Dalton's law. Dalton's law is the one that discusses the partial pressure of atmospheric gases. So it really is saying that the amount or the partial pressure of one gas in the mixture, one individual gas in the mixture, or all the individual gases in the mixture have to equal the total partial pressure of the mixture. Okay. So there's a little couple of differences in some of our terminology. So the differences being that pressure gradients are what makes the air move or the gases flow during ventilation, but those diffusion gradients are going to be what is going to cause the gas to move across that AC membrane or cause that respiration, internal respiration. Okay, so again, Dalton's law talks about the partial pressures. So total partial pressure exerted on a mixture needs to be equal to the sum of the pressures, okay, of each gas in the mixture. So the pressure exerted by each gas is called its partial pressure, and that is going to be proportional to the percentage or the concentration of gas in the mixture. So the partial pressure then is going to be proportional to like your FiO2, the concentration of the oxygen in the mixture. So if you're at 80% FiO2, you're going to have a higher partial pressure of oxygen than if you were at 21% FiO2. So this is just kind of a figure that's a visual representation of this law. So you're seeing in the first beaker gas A, gas B, with respective partial pressures of 10 and 5. But when we put those gases together, the partial pressure in that beaker is going to, of that whole mixture, is going to be 15, those two numbers added together. Okay, so applying partial pressure to atmospheric gases, each of the Earth's atmospheric gases, or the Earth's atmospheric gases consist of nitrogen, oxygen, and carbon dioxide primarily, and then there's some trace gases like argon and radon that are also factored in there, but they make up less than 1%. So the percentage of these gases do not change depending on your elevation, but because the entire partial pressure of the gas, the total partial pressure, or the atmospheric pressure changes due to elevation, then the partial pressure of these gases are going to change due to elevation. So if you think about this, if I draw a picture here, this is Mount Everest, right? And this is sea level. This is the ocean here. Those are waves. And if I draw my little dude here at sea level, the atmospheric pressure, or commonly referred to as the barometric pressure here, PB, barometric pressure, is going to be higher than the barometric pressure up here with this little guy who's sitting on top of the mountain. Okay, and that should make sense because the partial pressure on this guy, he's being affected by all the gas molecules that are above him. Okay, so there's way more gas molecules above him when he's at a lower elevation than when he's at a higher elevation. So that atmospheric pressure for him is higher down here at sea level than it is for him up here on the top of Mount Everest. Okay, so because the partial pressure of each gas is going to be related to that concentration, it's also going to be relative to the barometric pressure. Okay, so we're going to be able to figure out the partial pressure of each of these gases based on the barometric pressure at that specific elevation by multiplying the barometric pressure by the concentration of oxygen. So here's your example here. That at normal sea level, your barometric pressure is 760. So our concentration of oxygen is about 21%. So if I multiply those two together, I get an atmospheric partial pressure of oxygen of 159.6. Okay, so we did this calculation. This should be feeling pretty familiar to you guys. So I can do that calculation with any of the atmospheric gases, right? I can figure out the partial pressure of nitrogen, oxygen, carbon dioxide, and even the trace gases if I know that specific concentration. So if you're looking at this pictures in your book, you know, they say nitrogen's about 78%, makes up 78% of the atmospheric gases. So at sea level, the barometric pressure is 760, so 78% of 760 is about 592.8. Okay, we already talked about oxygen, but carbon dioxide makes up about 3%, or 0.03%, excuse me, so it's less than 1% there. So if I multiply 760 by 0.0003, very small percentage, I end up with like 0.2 millimeters of mercury. So again, super small percentage of, or super low partial pressure because of its low concentration. Okay. So just bringing this concept home again, you know, as that atmospheric pressure is going to decrease, with increases in altitude, the concentration of the gas doesn't decrease, but because the partial pressure of the gas decreases, it's going to have a lower diffusion rate, okay? So it's important to remember that even though the barometric pressure of oxygen, or the barometric pressure lowers on the top of Mount Everest, that concentration of oxygen is still 21%. It's 21% at sea level. It's 21% on top of Mount Everest. It's 21% in Sheboygan, Wisconsin, Fond du Lac, Wisconsin. Any place on Earth, the concentration of oxygen is always going to be 21%. But those barometric pressures are going to change, and that is going to change how much pressure, or the alveolar oxygen tension pressure. Okay. So as we go below sea level, our barometric pressure increases. So for every 33 feet we descend in water or go below sea level, we are going to increase our atmospheric pressure by 1 atmosphere. So it's doubling essentially. So at 33 feet below sea level, it's going to be 760 times 2 is going to be the barometric pressure. Okay, so at 33 feet below sea level, we're at 2 atmospheres or 1,520 millimeters of mercury. Okay, so as I go even further down, and I get to 66 feet below sea level, that's about 3 atmospheres. 99 feet, we're about 4 atmospheres. Okay, so that partial pressure exerted on every gas in the atmosphere is increased by 4 if I'm at 99 feet below sea level. Okay, so that partial pressure of oxygen then isn't going to be 159, it's going to increase to 636. Okay, and if you think about it in terms of rates of diffusion, things like that, I have my little alveoli here, and the partial pressure of oxygen in here is 636, and the partial pressure of O2 in this blood that's returning from the body is about 40. There's going to be a significant amount of kind of force or incentive for that gas, that oxygen, to diffuse across that membrane with that extra atmosphere. So this is that whole concept behind hyperbaric, excuse me. This is the whole concept behind hyperbaric chambers and using hyperbaric oxygen. So hyperbaric therapy is any application of oxygen at pressures greater than 1 atmosphere. Okay, so patients will be put in these sealed chambers and exposed to kind of selected oxygen concentrations at 1 to 3 times the normal atmospheric pressure. So typically, I think usually they'll increase the atmospheres to like 3 atmospheres when the patients are in there. They get 100% oxygen at 3 atmospheres. So that means their partial pressure of oxygen is going to greatly exceed what they would be able to achieve with just 100% oxygen at normal atmospheric pressure, right? So that means that the amount of oxygen that then diffuses across and dissolves in a liquid is going to be a lot greater. And that means that there's going to just be quite a bit more oxygen available in the blood to be transported around. Okay, so this can actually help a lot with different vascular disorders or infections or oxygen transport disorders to try to help improve wound healing and improve oxygen delivery to the tissues. Sorry. Okay. So remember that diffusion of gas, pressure gradients versus diffusion gradients. Pressure gradients is that movement of gas from high pressure concentrations to low pressure concentrations. That's what we talked about with ventilation. And then remember that each individual gas doesn't necessarily move in the same direction at the same time, right? So each individual gas is going to be moving dependent on its own partial pressure and pressure gradients, right? And we're going to talk about that, or we'll try to get you to understand that a little bit more when we're talking about the movement of oxygen versus carbon dioxide. So So gas diffusion is that movement of individual gas molecules of those areas of high pressure to the areas of low pressure. So those individual gases continue to move independently of each other. So that's what we're talking about with diffusion. So again, like I said, this is going to factor in when we talk about how oxygen moves from alveoli to blood and versus how CO2 moves from the blood to the alveoli during normal ventilation. So those gases are going to move in opposite directions based on their individual diffusion gradients. And the diffusion is going to continue until each individual gas partial pressure reaches equilibrium. So there's a nice chart in the book that talks about this, gives you some examples of the breakdown between your O2, your CO2, in the alveolar gas versus the arterial blood versus the venous blood. Okay, so if you think about it, when we breathe in, our O2 in that alveolar space is going to be at about 100, partial pressure of about 100, and the venous blood that's coming back to the lungs is about 40. So there's a big pressure gradient here that's causing this gas to move into this venous blood. Okay. So then when it leaves the heart, it should be almost about 90 millimeters of mercury. So this venous blood is going to bring it back to the heart and pump it. It's coming from the heart to the lungs, and then that alveolar or the arterial blood is what's going to be pumped back out to the rest of the body. In reverse is our CO2. We have a lower level of CO2 that's going to be in our alveoli because that's what's going to have been breathed in from the external environment. Our venous blood that's bringing that, which is essentially the blood that's going to be going to our lungs. It's going to have a higher concentration, so CO2 is going to go from blood to the alveolar space. So diffusion is going to happen for each of these things during ventilation, but they're going to happen in different directions. Okay. So this chart here is just a relationship between temperature, humidity, and water vapor pressure. And this is important because water vapor is water molecules. So that then, or that's a kind of gaseous state of water. So that water vapor is going to factor into the total partial pressure of that mixture because it's part of that gas mixture. So those two tables really explain why your PO2 in the atmosphere is so much higher than the PO2 that actually is in the alveoli. If you noticed on that chart, you had the atmospheric PO2 of about 159 and the alveoli PO2 of about 100. Okay, so why that is you have to subtract that from that total partial pressure, you have to subtract the partial pressure of water first. So water being a little pointer thing. So if we think about the atmospheric pressure of 170, we're going to subtract 47 first, which gives us minus 47, gives us 713. 113. 113 times 21. It's going to be about 149, and that minus the 40 for the CO2 drops you down to closer to 100. So minus 40 for the CO2. 113, oops, excuse me, 713 minus 40 is 673. And that gives you closer to 100. Okay, so we're going to see this in action when we go to that alveolar partial pressure of oxygen, oxygen tension calculation a little bit later on. So, remember, water can exist as a liquid, gas, or a solid. That water vapor is molecular water. And when we're at normal body temperature, that molecular water exerts a partial pressure of about 47. So just reminding you about humidity a little bit. Water vapor is, like I said, that at 37 degrees, it's going to have a partial pressure of 47 millimeters of mercury, and it's going to have an kind of actual content of about 44 milligrams per liter. So that's the volume of water that's carried. So relative humidity is calculated out by the actual content divided by that max capacity. The max capacity at that 37 degrees would be that 44. So 100% relative humidity would mean that you have 44 milligrams of per liter at 37 degrees Celsius. Divided by the max capacity, which is 44, which gives you 1 or 100%. Okay, humidity deficits happen whenever that max capacity or the actual content doesn't equal the max capacity. Okay, so you have humidity deficits there where you have not enough water or not as much water as you possibly could have, which will dry out your mucous membranes and slow your mucociliary transport and lead to problems with your patient's ventilation. All right, so that ideal alveolar gas equation, this is, again, something that you did with me last semester. So clinically, we can calculate this. This is a good calculation to know. I feel like this has come up on board exams before. Not every calculation does, but this is a common enough one that this is an equation I think you should kind of have committed to memory. So when you're looking at the big A in any calculation or any reference, so that's capital A here, that is talking about alveolar. This lowercase a over here is talking about arterial partial pressures. So big A is alveolar, little a is arterial. So just to know that, I think that that's always a hard thing when I'm trying to instruct you, because it's like when I read these things, it says PaO2. Well, there's P capital AO2 and there's P lowercase AO2, and those mean two different things. And we talk about with gas transportation and things like that and oxygenation, that AA gradient or the difference between those two partial pressures is going to tell us a lot about how well our patient's diffusion is working. All right, so to calculate this out, we're looking at the barometric pressure minus that partial pressure of O2 multiplied by the FiO2 or the concentration of oxygen, and then we have to subtract the partial pressure of carbon dioxide. Okay, so this is one of your worksheet questions. You need to do this calculation for me. Remember that if your FiO2 is greater than 60, you get rid of this coefficient over here or here. Okay, so this calculation is written two different ways. Just pick a way to do this and remember just the one way. You don't have to remember both ways. I prefer this guy here because I like multiplying rather than dividing. I don't know if that's a weird thing to have a preference about, like who even thinks that much about math that has a preference over multiplication and division, but apparently I do, and I prefer multiplication, so I have this one memorized versus this one down here. But doing this calculation either way is fine. You're going to get the same answer. Just memorize one of them. Okay. All right, so here's just an example, plugging the numbers in. You're given an FiO2 of 40% on a day that the barometric pressure is 755. The patient CO2 is 55, and they want you to calculate out the patient's oxygen tension. So you're going to take that barometric pressure of 755, plug it in right here. Partial pressure of water is always going to be 47. My FiO2 gets plugged in here. My PCO2 gets plugged in there. All right, I do some math, do parentheses first, which gives me 708. Do this multiplication over here, that gives me 78.75. Then I multiply this 708 by 0.4 to give me 283.2. Subtract the 68.75, and I arrive at my final answer of 214.45. Okay. So if you think about this mathematically and you think about this calculation, you can kind of understand how if I increase this number here, my barometric pressure, that is going to increase this number here, right? So anything, so this barometric pressure, if this number is higher, no matter what it is, and everything else is the same, I'll end up with a higher number here. Okay, because I'm ultimately subtracting this half of the equation, if I increase this number here, that is ultimately going to lower this number down here. If I increase this number here, the FiO2, that will ultimately also increase my PaO2. Okay, so my barometric pressure, my oxygen concentration, both of those things would increase my oxygen, partial pressure of oxygen tension. An increase in my CO2 though, my partial pressure of CO2 in my arteries is going to decrease my oxygen tension. Okay, so that is, if you think about that with a patient that has like emphysema, who can't ventilate very well. So if I have a patient that has emphysema, who can't ventilate very well, that means that the air is not getting back out of these alveoli very well. So that means the CO2 here starts increasing, right? And because the CO2 is increasing in that alveoli because it's not ventilating well, then my pressure gradient between here and here gets, let's say, narrower. So I don't have as much of a pressure gradient between the two of these. So because there's not much of a pressure gradient anymore, CO2 is not going to want to diffuse this way, and it's going to stay in that arterial blood, okay, which makes it harder for oxygen to get over here and dissolve because there's not enough room for it to do it, if you think about it that way a little bit. So my partial pressure of oxygen here can't be very high. It's going to lower in here. It's going to be decreased in here because the amount of CO2 that gets into there is going to be increased. So if my CO2 levels are high, my pressure of CO2 is high, that means ultimately my partial pressure of oxygen is going to decrease. I think that made sense. Hopefully that made sense. Okay. So your ideal alveolar equation, remember that when our FiO2 is greater than 61%, then you're not going, 61% or greater, then you're not going to multiply by the 1.25. All right. So that's kind of the main gas law that talks about the pressure gradient or the diffusion gradient, or the things that are going to affect diffusion gradient in the lungs. But there are other barriers that happen that are going to affect diffusion, and that really has to do with this AC membrane. Okay, that's what the molecules, these gas molecules, has to kind of transfer through in order for blood to get from the alveoli, or oxygen to get from the alveoli into the blood. Okay, so typically your AC membrane should be about 2.5 microns thick, which is super, 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 super small. Okay, so that normal gas pressure for O2 and CO2 to move across that AC membrane. So this is just kind of plugging those numbers in, where you have your P, big AO2 being that 100 as listed before, and in your blood here, it's about 40. So oxygen is going to want to diffuse from the alveoli into the blood. And CO2 is going to be higher in the blood and then lower in the alveoli, so CO2 is going to want to diffuse the opposite way. So after the blood passes past the alveoli, it gets reoxygenated, and you have more normal levels of, your arterial O2 and your arterial CO2. Okay. So under normal conditions, our perfusion, or how fast that blood goes past the alveoli, is about 0.75 seconds that blood flows through there, right? And diffusion should only take about, in normal people, should only take about 0.25 seconds. So there's plenty of time for this diffusion to happen. There's 3 times as much time needed for the diffusion to happen based on the rate of blood flow. But during certain types of activities, your blood flow is going to kind of be increased, right? So during exercise or stress, that blood flow is going to be sped up, and then it's going to have less time than normal for that diffusion. In healthy individuals, this isn't a problem. So if I go and I run a mile, I should be able to run that mile without having low oxygen saturations, right? If you put an oxygen monitor on my finger, pulse ox monitor on my finger, I should not desaturate by even running a mile, right? My heart rate's going to go up. I'm super out of shape, so I might not feel the best running that mile, but my oxygen level will be maintained at a normal level, okay, even being out of shape. But if I had certain types of lung diseases like pulmonary fibrosis, so what happens in pulmonary fibrosis is you have kind of a thickening of that interstitial tissue around those alveoli and capillaries. So that makes that AC membrane quite a bit thicker. That slows down the rate of diffusion. And as my normal diffusion rate is already slow, but if I speed up my blood or my perfusion during times of exercise or stress, that makes it so that potentially I wouldn't have enough time for that diffusion to happen. And that's why you see a lot of patients that have fibrotic lung diseases like pulmonary fibrosis, they require quite a bit of oxygen while they exercise, because we need to increase that oxygen concentration, increase that diffusion gradient, so that we can hopefully speed up that rate of diffusion enough that the patient can maintain normal oximetry during exercise. But a lot of times you'll see your pulmonary fibrosis patients or patients with like interstitial lung disease, they're going to be the ones that are going to require the most oxygen at home because of this. Okay. So this just kind of is a picture of that. So the rate of diffusion decreases because of that alveolar thickening. And then that oxygen equilibrium isn't likely to occur. So there isn't likely that the oxygen is going to have enough time to equal for that diffusion to happen and that equilibrium to happen to stop diffusion. So it's just going to keep going through too fast, and it won't have enough time to be picked up by the blood, those oxygen molecules. So this is just a little bit of a reminder about Fick's law and all the things that factor in to diffusion. So your V here is your diffusion of gas. So V is your diffusion. Your A is equal to the surface area in the lungs. So there are certain lung diseases that affect alveolar surface area. And those diseases, if I decrease my alveolar surface area, I'm going to decrease my rate of diffusion. This one is not so important because it's your diffusion coefficient. So if you think about it, we're only ever talking about oxygen or carbon dioxide, so it's not going to change for the individual, right? My gas stays the same, so nothing with my individual is going to change my diffusion coefficient, so that's really not a factor. But my pressure gradient, so this would be like my partial pressure of oxygen in the alveoli, big A, and my partial pressure of oxygen in the arteries, little a. So how big of that diffusion gradient is. The higher the FiO2, the higher the P big AO2, the bigger the gradient, the more motivation there is for diffusion. And then over here is thickness, right? So as my thickness increases, my diffusion will decrease. Right, so this is just kind of a picture representing that concept. So again, that D really doesn't factor in because we're talking about the same gases, so the diffusion coefficient is going to be the same. So oxygen is going to go from the alveoli into the blood. It has to pass through that alveolar tissue area, so that thickness is going to be a factor in how well that's able to be accomplished. Carbon dioxide is going the opposite way. The P1 is the arterial partial pressure of carbon dioxide in the blood versus the alveoli. Okay. So when you're thinking about the diffusion coefficient, what goes into there, that really, this is going to be a couple slides of kind of background information, but I want you to just, at the end of it, we're going to arrive at the key point, which is carbon dioxide is more soluble than oxygen, like 20 times more soluble than oxygen. So just bear with me for a little bit to give you some background information, but the key concept to remember over the next 3 slides is that carbon dioxide is going to be more soluble than oxygen. All right, so the amount of gas that dissolves in a liquid at a given temperature is proportional to the partial pressure of the gas. This is Henry's law. We talked about this. This is that soda bottle concept, right? So an ice cold soda is going to have more dissolved carbon dioxide than, you know, a warm flat one. So the solubility coefficient is related to the amount of gas that can be dissolved. So the solubility coefficient for carbon dioxide is going to be bigger than the solubility coefficient for oxygen. More carbon dioxide can dissolve in a substance than oxygen. Graham's law talks about the fact that gas is going to be, the diffusion of gas is going to be proportional to the solubility coefficient. So how soluble something is going to, how likely something is going to be diffused across this membrane is dependent on how soluble it is. So, but then it's inversely proportional to the molecular weight of a gas. So, you know, the more soluble it is, the more likely it's going to diffuse, but the bigger it is, the less likely it's going to diffuse. So, so then if you do kind of calculate it out, the diffusion rate for CO2 versus the, you know, gram molecular weight of O2 versus CO2, you kind of arrive at this combination of these laws. So again, diffusion is going to happen more likely if it's more soluble, and it's going to be less likely to happen if the molecule is bigger. And both of those factors, when you combine them together, is the reason why CO2 is going to diffuse about 20 times faster than oxygen. Okay, so that's the important concept with that. CO2 is going to diffuse much quicker than the oxygen is. Okay. So in order for any of this to happen, you have to have perfusion and ventilation. So we talked about ventilation perfusion ratios and VQ mismatches, again, back in survey. So perfusion limited means that the transfer of gas across that alveolar membrane is kind of the function of how fast that blood flows. So if I don't have blood going to these alveoli, I could be ventilating as good as, I'm doing an amazing job ventilating. My alveolar can all be working well. I can have really, really normal AC thickness, but if I don't have blood flowing through those capillary beds, diffusion can't happen. And that's the concept behind perfusion limited. Okay, so when you think about perfusion limited, you can think about nitrous oxide, which is a anesthetic gas that's typically used in anesthesia, surgery, and it's kind of a good gas to illustrate this concept because it moves across that alveolar. Once it moves across that alveolar wall, it doesn't combine with the hemoglobin. It just gets dissolved in the plasma. Okay, so because of this, that's an importance. Let me take a step back. So oxygen will combine with hemoglobin, carbon monoxide will combine with hemoglobin, even CO2 can sometimes combine with hemoglobin and carry with hemoglobin. So anything that's bound to hemoglobin isn't going to factor into the partial pressure of the gas in that liquid. Okay, so the oxygen molecules that diffuse across the AC membrane and get into your blood but bind with hemoglobin, they aren't going to be part of that partial pressure of oxygen. Okay, so I just want to make sure that that's clear to everybody. I don't think we've talked about that yet. So when it comes to nitric oxide, that is going to not chemically combined with hemoglobin, so that because it's only dissolving in the plasma, that partial pressure of nitric oxide is gonna kind of raise really quickly. Okay, so because it's going to raise really quickly, then it's going to reach its equilibrium and diffusion is going to stop really fast also. Okay, so in order for diffusion to continue, you need to have more blood, new blood that doesn't have any nitrous oxide dissolved in it, coming into contact with that alveoli. So then that means that in this scenario, the amount of nitrous oxide that diffuses across this membrane is going to be dependent on the flow of blood through here. So the more perfusion that happens, the more nitrous oxide that comes into the blood, right? If the blood is really slow, that diffusion rate is going to be really low. So that's kind of a good example of perfusion limited. Okay. Then we have things that are diffusion limited or ventilation limited. So this is the movement of gas across that alveolar wall function is kind of dependent on that integrity of that AC membrane itself. So how thick that membrane is or how much surface area there is with that membrane is really what's affecting how much gets through. So carbon monoxide is a good example of diffusion limited gas. So carbon monoxide is typically used in pulmonary function labs to give us a picture or help us diagnose diffusion issues in the body. Carbon monoxide is a gas that readily, once it moves across that alveolar membrane and gets into the blood, it's going to rapidly like bind with hemoglobin. So as I mentioned before, molecules that are bound to hemoglobin isn't going to exert any partial pressure. So the partial pressure of carbon monoxide in this capillary blood is going to be relatively low because it's all going to be bound to this hemoglobin. Okay, so that means that more and more CO2 is going to want, or CO is going to want to diffuse across that membrane because that partial pressure is very, very low in the plasma. Okay, so that means that diffusion is going to be limited not by the blood flowing through here, but by things that affect your diffusion rate, like your AC membrane thickness or alveolar surface area. Okay, so some clinical conditions that might cause, diffusion problems could be alveolar collapse or atelectasis. So I'm not getting any diffusion because I'm not getting any ventilation here. Thickening of the alveolar wall, like we mentioned with pulmonary fibrosis. You can have destruction of the alveolar capillary relationship. So again, that is destroying the surface area. So less alveolar surface area, less diffusion, consolidation, pneumonia. There's no oxygen getting into this alveoli, so it's kind of wasted perfusion here. This can't be ventilated, so all of this perfusion is going past an unventilated alveoli, just like with the atelectasis. Pulmonary edema kind of creates the same scenario where you have a lot of fluid filling up that alveolar space, so ventilation can't get in. And then interstitial edema. So sometimes with inflammation, interstitial edema as seen in patients with adult respiratory distress syndrome or infant respiratory distress syndrome could cause this thickening of this interstitial space, meaning that there's going to be more that thick. Again, it's going to work just like alveolar wall thickness, and it's going to slow down the rate of diffusion. So ventilation really is supposed to match perfusion, right? The amount of ventilation that we have is supposed to kind of be close to the amount of perfusion that we have. So ventilation perfusion matching is that VQ ratio, V standing for ventilation, Q for perfusion. So if this is increased, that means that there's too much ventilation, and that ventilation isn't coming into contact with blood flow. So this is wasted ventilation or dead space ventilation. So this can happen if there's like a pulmonary embolism that is clotting off a certain area of the lung. Air is getting into that lung, but blood is not flowing to that those alveolar space. And we have a VQ mismatch or an increased VQ ratio, and we're kind of perfusion limited. A decrease in ventilation perfusion is where you have too much perfusion but not enough ventilation, or wasted perfusion. So this is shunted blood, where that blood is coming into contact with alveoli that aren't getting ventilated. So like a pneumonia or pulmonary edema could cause this. So this is, again, that diffusion limited or ventilation limited diffusion issues. Okay. Just to give you a little bit more information or a better visual on pulmonary edema, this is kind of a cross section of the alveoli with that pulmonary edema present. So typically when patients have pulmonary edema, this can be cardiogenic or non-cardiogenic in nature. So cardiogenic pulmonary edema is kind of a fancy way of saying heart failure. So when our heart isn't pumping properly, or left ventricle is not pumping properly, blood gets kind of backed up. It backs up into then the lungs. And then that's going to increase the pressure that's in all of those capillaries. And that pressure in the capillaries, once it exceeds the pressure that's in the alveoli, you're going to start having fluid seepage out of the capillaries or that vasculature into the surrounding tissue. So you're going to have interstitial edema, kind of fluid engorgement in that alveolar wall interstitium, and then the patient, typically one of the main signs of cardiogenic pulmonary edema is kind of pink frothy secretions, or white frothy secretions that they're kind of coughing up some of that excess amount of fluids. I've had patients go into flash pulmonary edema and they just get just an obscene amount of frothy secretions that you just feel like you are never endingly suctioning out of the patient. This can also be, so that's cardiogenic pulmonary edema. That's kind of the process for how that happens. But then there's non-cardiogenic pulmonary edema that can happen due to any type of lung injury or trauma that's causing that inflammation and that extra fluid to build up. So patients that have, like, sometimes they have really bad pneumonia or something like that, they can end up with pulmonary edema. Non-cardiogenic. That's not as common. Cardiogenic's the more common one. We usually see it because of the hemodynamic issues with heart failure. But either way, that pulmonary edema is going to increase that alveolar wall thickness, AC membrane thickness, and slow down the rate of diffusion. Okay. So as I mentioned, we use carbon monoxide in pulmonary functions labs, and we do a test called the diffusion capacity of carbon monoxide test, or DLCO test. This measures the amount of carbon monoxide that moves from that across that AC membrane into the blood at a given time. So really what it evaluates then is the effectiveness of that AC membrane. So typically it should be around 25 milliliters per minute per millimeter mercury, but certain conditions can affect the rate of diffusion. So age, we progressively diffuse better as from birth to about 20 years. We get, just because we're increasing our alveolar surface area, our lungs keep growing until we're about 20 years of age. And then after that, we're going to start seeing it decrease just because of some of the structural changes that happen as we age. Lung volumes, obviously diffusion is going to be better the bigger our lungs are. So if I'm a larger, taller, by larger I mean taller individual, I'm going to have larger size lungs. So I'm going to have greater surface area, greater DLCO. So that body size rule is really dependent on, and lung volume is dependent on my kind of ideal body size. So the taller I am, the bigger my lungs are. Body position. So diffusion is going to be, greater in somebody that's in kind of the supine position versus the upright position. And that has to do with perfusion, right? If I don't have good perfusion, I'm not going to have, diffusion can't occur. Exercise, DLCO is going to increase with exercise because, again, I'm having that faster perfusion, better cardiac output, better capillary retention and distension associated with exercise. Alveolar O2, so that P big A O2, the higher the concentration there, the more likely it's going to, the less likely, than that CO2 is going to be able to bind with hemoglobin. This is why we can't have the patient on oxygen before we do the DLCO test, because then oxygen could possibly be bound to the hemoglobin. Even though it has a better affinity for carbon monoxide, if I have enough oxygen in my blood dissolved in my plasma, then some of it is going to be bound with hemoglobin, and that's going to reduce the ability or compete with the carbon monoxide and reduce the carbon monoxide's ability to bind with hemoglobin, decreasing your DLCO levels. Hemoglobin concentrations, again, if I'm anemic, I don't have a lot of hemoglobin available. So that means there's not space for that carbon monoxide to bind to. So I'll have a low DLCO value. And then polycythemia is patients that have high hemoglobin concentrations. So it has a high carrying capacity for CO, so a higher DLCO value. And then carboxyhemoglobin, so these are for people that already have carbon monoxide bound to their hemoglobin before the test, so smokers. This is another reason why we tell smokers that they're not allowed to smoke before their pulmonary function tests. So these conditions potentially would reduce your DLCO levels as well. So again, your oxygen can either be, how oxygen is going to get into your blood can either be perfusion or diffusion limited. And that is going to be dependent on how gas is going to transfer across that alveolar wall. Okay. So diffusion limited means the movement of gas across that alveolar wall, and the integrity of that AC membrane itself is what's limiting the oxygen moving through that space and moving into the blood. Okay, so diseases like emphysema, pulmonary fibrosis, pneumonia, pulmonary edema, all of those diseases that we kind of covered in that figure 4-12 are going to be diffusion limiting problems. All right, well, hopefully this is better. It was certainly a lot quieter and less distracting for this one. Let me know if you have any questions.